recording. So, okay, so this is just the PowerPoint. Let's see, there we go. Okay, so the goal for today is not only to talk a little bit about what it looks like to be a healthcare professional in terms of logistics and the pipeline and the training and all that, but also what it would feel like. And so for that, we have just an example case, and we're going to let you guys play the doctors. And so we'll kind of stop at various steps along the way and see what you guys think about this patient coming in, what might be going on, what you might like to do, and so on. So this is our patient. Okay, can I get a volunteer to read the first two paragraphs, then maybe a volunteer to read the second one?
Sure, I can read the first part.
Thanks so much.
Mrs. Smith is an 86-year-old female who was sent by Vickery Nursing Home to the emergency room for evaluation. When you check her chart, the chief complains saying not herself. You speak with both the RN and the CNA who have cared for the patient since she came to the nursing home and obtain the following information.
Great, thank you so much. How about for the second paragraph? Sorry.
Okay, I can read that.
Thank you.
History of present illness. Approximately 2 days ago, Ms. Smith's appetite decreased. This morning, she woke up complaining of severe pain all over her body. The CNA reports that Ms. Smith may have had a fever and cough. She appears sicker than usual and has been having difficulty breathing.
All right, thank you. So just from this alone, from some of what's been said, this patient who doesn't feel herself, she's feeling this severe pain, she might have a little fever and a little cough, she doesn't look so good. Just as a first pass, are you guys concerned about her? Do you think that she needs to be worked up and we need to figure out what's going on? Or do you think this might be something that is not as high of acuity and she might actually be okay?
There are no grades and there are no wrong answers. This is just for fun.
Yeah, it's just for fun.
I think there might be something wrong, and we should do further testing to see if she's having like any other concerns or if just something that's in her mind, I guess.
Yeah, I think that's great. And the reason why I say that, and I apologize, I phrased it a little bit strangely, is one of the first instincts you have to develop as a healthcare professional is this patient sick or is this patient not sick? And it can be kind of hard sometimes. I mean, usually people who are coming in, there's something wrong, but there are various levels of health challenges that someone may have. And some of them, they maybe need to see immediately. And if you don't do something within the next, say, 24 hours, they could really go south. And so just kind of early on, thinking about being able to look at a patient very briefly and say, how quickly do I need to act upon this is a very useful skill. And just to kind of explain some of the language in this is some of the language that healthcare professionals use to talk amongst themselves, but maybe kind of hard to interpret if you don't have experience. Something like the chief complaints, what is meant by that is it's the principal concern of the patient. So that's why this patient is here, essentially. And then history of the present illness just means what's going on, essentially. So if you ever hear terms like that, that's just kind of jargon that's native to the field. And Edie, I don't know if you want to just kind of briefly explain kind of the role of the RN and the CNA, kind of what they are maybe, and what they may be doing to help triage a patient like this.
Watch it. Is it the next slide? Yeah, go to the next slide there.
Okay.
So there's lots of levels of, we want you to understand that there's lots of different fields that are in the medical community, right? So there's a doctor, there's a nurse, there's all these other people. But some of the levels in nursing care are the CNA, the Certified Nursing Assistant. You can have gone to a high school, maybe taken a little 6-week class or something, and you can kind of get your foot in the door, and you're doing vital signs and giving people baths and that kind of thing. There's different levels. Then there's the LVN in Texas, the LPN, and you go to high school and then you do a 2-year program, and you're a nurse. And then above that is a registered nurse, and it can be a 2-year program in a community college, or it can be a graduate program. I graduated from college with mine, and that's what I have, a BSN or an RN. And then there's a medical assistant, and that's kind of like the CNA, but they actually work underneath a doctor, and the doctor is over their training. And he said, and if the doctor says, okay, you can give people shots, you can do this, they can do a little bit different. It's just kind of funny. And then there's a side that I don't understand as well, but it's going to be a doctor.
Yeah, so this is a different pathway. This is the pathway that I'm currently personally on. So after high school, you guys are juniors and seniors in high school, and so the next step is college. It's a 4-year degree for a bachelor's degree, and then it would be another 4 years after that for medical school. And that's kind of the end of your formal, mostly class-based learning, because after that you enter something called residency, which lasts anywhere from 3 to 7 years, depending on what you're interested in. So if you want to be a pediatrician, for example, and take care of kids, then it's 3 years. If you want to be an orthopedic surgeon and do surgery on bones in the body, it's 6 years. And if you want to be a neurosurgeon or a general surgeon, where you take care of the brain or you operate on kind of the intestines and bowels, then it's 7 years. So there's a wide range, and it just has to do with kind of the breadth of things that you're expected to know when you graduate. And it's kind of a apprenticeship type model where it's not really school anymore. You're working all day, every day. You're in the hospital, or you're out in the community in clinics, but it's still with some supervision from some more practiced and experienced individuals. Then after that, if you're still really excited about training after the, up to 15 years, you can do a fellowship. And fellowships are usually, mercifully, just a year. And that's if you want to be even more specialized. So maybe you don't just want to operate on the bones, you want to operate specifically on the knee. Or maybe you don't want to just take care of all children, you want to take care of any kind of infection in children. So for that, you would do a fellowship, and it would really narrow the focus of what you're doing, but it does require a little bit of extra training. And then finally, after that, you're out on your own. This can be kind of overwhelming. This is not something that I thought about when I was at your stage. I kind of stumbled into this, and maybe at the end we can have more time to talk about this. But the good news is that it's really fun as it goes. And so, I think the best way to think about this is, if you're passionate about it, it's not like you're just waiting to get to a point where it's enjoyable. Each step along the way can be really enjoyable. And that's true whether you're training to be a doctor, whether you're training to be a PT, whether you're training to be a nurse. Even when you're in training, you still get to interact with patients. You're still learning all this cool stuff. And so it can still be very rewarding while you're in the pipeline. So I know this is intimidating, but if it's really what you want to do, I wouldn't let it discourage you, as it can be really exciting even along the way. So that's not all that there is in terms of what you can do in medicine. There are many, many other fields within medicine. So there's a nurse practitioner, and another thing kind of on a similar level is a physician's assistant, where they attain a little bit of extra training beyond what's kind of maybe baseline for some nursing professions. And they work in kind of this middle ground where they work they do certain things that physicians would do and certain things that nurses would do. And so they're this kind of nice in between. You know, everyone brings something extremely valuable to the team. So it's not a matter of worth or anything like that. It's just really a matter of how much training and kind of the specific role you're asked to do. And so, you know, the nurse practitioners do something kind of in between. There's a home health aide, which, you know, is maybe similar to kind of a travel nurse that was mentioned earlier, where you're going into homes and you're seeing how people are, where they're living. And that can be a really cool opportunity. There's occupational therapy, which helps people do something called activities of daily living. And that's just a very fancy way of saying, helping people take care of themselves. So are they able to do their bills? Are they able to, you know, get out of bed? Are they able to cook for themselves? That kind of thing. And there's physical therapy, which helps you get nice and strong. So say, you know, you go into some kind of surgery, and surgery takes a lot of out of people. And so they need someone to help them get their strength back. And so that's what a physical therapist will do. But even with all that said, that is still just a very small portion of the number of fields you can go into within medicine. And so don't worry, I'm not going to read off everything on this list, but this is just to kind of give you guys an idea of what there is. And so a lot of these things interact directly with patients, but there are other complementary fields like being an engineer and designing products that are used by nurses and that are used by physicians. There are all sorts of fields that you can go into where you can still interact with people and still be in the health realm. So with that, I'm actually going to pause here briefly. I'll circle back to that last slide, but I'm going to pause here briefly for any questions you guys have. Any questions about, you know, the training pipeline, what you can go into, what that training looks like for a nurse, what that training looks like for a physician, kind of a more day-to-day level. You know, Edie and I are happy to answer any questions. And if not, it's okay. You know, we'll just move on.
I have a question.
Yeah.
Are LPN nurses similar to registered nurse?
This is one little detail. An LPN is a licensed practical nurse, and they are the same as an LVN, but I don't know why. Different states use different titles. And so an LVN is officially the one that's in Texas. They do many of the same things, except an RN is just that step above. So an LVN always has to have a registered nurse somehow supervising her or being somebody she would.
You are mute.
That whole time I was on mute.
No.
We heard most of you, Edie. It was just kind of at the end.
I'm so sorry. Okay, start all over again. So an LVN and an LPN are the same thing, but an LVN is what we call them in Texas. Okay, licensed vocational nurse. Excuse me. I didn't want to cough in your ears. An LVN is a step under an RN, and LVNs, if you walked into a hospital, if you walked into my clinic, I work with an LVN every day, and we would do the same job. But she has to have an RN that's above her at some level. It's just the way our licenses work, because RNs have just more education, more specific source of education. So, and LVNs make less money because of that. They also have a little bit, maybe smaller group of jobs that they could take. An RN, in my opinion, has just more freedom to, you know, go into a hospital, go and do a lot of different kinds of jobs than an LVN does. So my recommendation for anybody is, if you're able to go for the RN first, and then, you know, then you just have, you get more income, you can support your family better, yourself. You can just, it's sort of like the world's your oyster, you know, as far as a nursing job, you can kind of choose a lot more things. Does that help?
Yes, thank you.
Okay.
Awesome. Any other questions at this point?
Yes, I actually have a question for Eddie. You mentioned that you are a nurse, so I was wondering what kind of nurse are you and what do you do in that field?
Right now, I work for Dallas County Health and Human Services, the health department, and I give vaccines to children. So if in the past 4 years you've had to go to Spring Valley and go to get shots, maybe you did that when you were a little younger. In the 7th grade, you have to get this set of shots. I might have been the one to give them to you. All I do right now is give vaccines to people. But in the past, I have worked in emergency rooms where, I took people off stretchers and set them up and figured out, oh, they're having a heart attack. Or I have worked in hospice where people are dying and I've been with them at the last minutes of their life. I have worked in nursing homes. I have done home health care with children. I've worked on hospital floors. I've done many, many, many different kinds of things. And honestly, every one of them I enjoyed. Nursing is something that is vast. Like my friend Gray, he's going to operate on brains. That's what he's going to do. He may be able to do other things, but that's going to be his job. But as a nurse, you can do so many different things. And like as a traveling nurse, you could end up working in an ER one time, and then maybe you could choose a pediatric floor another time, and you could do home health another time. I love my job, and there's a wide variety to it if you want there to be, or you can specialize in one thing and do that for the rest of your life and be happy also.
Okay, thank you.
Uh-huh.
And I'll say as well, just kind of as a aside, I know plenty of people who are nursing or nurse practitioner, and one thing they really talk about, what they love about what they do, is that flexibility. It doesn't get stale. If you want to work in an orthopedic surgery clinic for a couple of years, and then you think, oh, maybe I want to go see some kids and do vaccinations, you can make that transition. And it's really cool that you can do that and have just a really broad understanding of medicine. And like Edie was saying, when oftentimes physicians get very narrow. And so, if someone were to ask me about the pediatric vaccination schedule, Edie would know that forwards and backwards, upside down, I'd be like, I don't know, ask Edie, And so she has a very excellent, broad general knowledge, and physicians get very kind of maybe sometimes in some people's minds too focused. So you just have to kind of know yourself, know if you'd like to be broad, if you'd like to be narrow. But that's one kind of difference that people really kind of like in nursing. So any other questions right now? All right. So Edie, do you want to do the next section, or do you want me to keep going? And it's up to you. I don't want to monopolize the the conversation, but the next.
Ray, you're doing fabulous. And the next is a physical exam. So
Okay.
I'll jump in there if I want to, but you go ahead. You're doing well.
Okay, sounds good. All right, so first, we talked a little bit about the patient. We said that we're feeling like, she's sick. We want to know what's going on. One thing that can be really helpful to healthcare professionals when you're trying to figure out what's going on with the patient is, what do they have going on in their past? Have they had a similar issue before? Maybe this fits the same pattern that we've seen in the past, and that can help us make a diagnosis, understand what's going on. A lot of working in healthcare is being somewhat of a sleuth, being a detective, and trying to sniff out what it is that's going on. And knowing what happened in the past is very useful. So this is a slide for our patient talking about what kind of things she's had going on in the past. And so we know that she has high blood pressure, and she has high cholesterol, and she has heartburn, and she used to smoke a lot. And who has known someone who's had high blood pressure or heard that term before? Yeah, so it's really common. So just as kind of a broad background, we have blood, and that blood carries oxygen, which is what we're breathing in, to all our tissues around the body. And all our tissues around our body need that oxygen to function. And the blood pressure is what actually gets the blood and the oxygen there. So if you have no blood pressure, then you're not getting any oxygen, any tissues, and that's really bad. But if it's too high, that can also damage those blood vessels over a long period of time. And that can set you up for some illnesses down the road. So that's why we pay attention to that. It's kind of the same thing for cholesterol. Has anyone heard of high cholesterol or known anyone with high cholesterol? Yeah, so it's also really common. And what happens with cholesterol is a kind of lipophilic, so that's a fancy word, but it's a kind of fatty substance that likes to get into the walls of our blood vessels, the stuff that's carrying around our blood and our oxygen. And over time, that can also damage the blood vessels. And so if you have high pressure and you have this kind of fatty substance in your blood vessels, that can lead to these health issues. And how about heartburn? Has anyone had heartburn before personally? I know I have. Okay. Well, hopefully it's not coming. Hopefully you guys won't experience it, but it's pretty common, you know, and it's not necessarily a red flag for anything bad. It could be you had some really spicy food and you laid down right after you ate. And then it's this kind of burning sensation kind of underneath your chest, kind of right here. And so when we say heartburn, it's a little bit of a misnomer, meaning it's not really accurate because it's not actually the heart and it's thankfully not actually burning. If our heart were burning, we'd have larger problems. But what it is just a little bit of acid from our stomach that comes up and goes into what we call the esophagus, and that hurts. When anything acidic, meaning there's a lot of hydrogen ions, if you remember from chemistry class, anytime substances like that get into areas of the body where they're not supposed to be, it can burn. And so that's why we call it heartburn, because it feels like it's around where the heart is, even though it's not, and it burns because it's acid. And so, but it's very treatable, but it can also be a sign of other issues. And then smoking. Who's known someone who's smoked, or you know, and kind of, have you guys been taught or heard about the issues associated with smoking? Yeah, so, you know, 50 years ago or so, we didn't really understand all the health impacts of smoking, but now we know it's really bad for you. And it's tough because some people started smoking before we knew that. And then unfortunately, it's really hard to stop once you start. And so the high blood pressure, the fatty substance and cholesterol and the smoking, these all kind of converge to make you higher risk for health issues. And so that's why we kind of like to just take a brief look at the patient and their past and see if we can understand what's going on. Okay. So now for hopefully one of the fun parts. So we're going to talk a little bit about the physical exam, okay? So kind of as a very brief, kind of broad overview, when a patient comes in to see you, you want to do 4 things, okay? And you can follow the mnemonic SOAP to guide you along those 4 things. The S stands for subjective, and that's what we just talked about. There's the patient's history. You know, talking to the patient, what's going on? How are you feeling? When did this start? Where's your discomfort? Have you had any issues like this before? Do you have high blood pressure? You know, that kind of subjective historical information. Then the next part is objective. And that objective part means the physical exam. So after you've talked to the patient, you'll want to do some exam maneuvers to see if you can hear or see what might be causing the issue. And so this is always where a physical exam starts. It starts with the vitals. Has anyone heard the term vital signs before? Nice. Yeah. So I don't think I had before medical school. And so it's totally okay if you hadn't. But the reason we call them vital signs is because they're vital. So if they are messed up, if they're not looking good, then the patient isn't looking good. And so we always want to start there. And so starting with temperature, if you remember our Miss Smith, she felt like she had a fever. And what a fever means is that our body temperature is high. And so does anyone know it's on the slide, but does anyone know the normal body temperature for us humans?
102 Fahrenheit.
Okay, so that's a little on the high side, but it's in the right ballpark. Yeah, so the normal body temperature is about 98, but it's kind of a range. Once it gets above 100, we start to call that a fever, meaning that they're a little bit hotter than we would like to be. And that's actually a sign that something is going on in the body that we don't want going on. And it's actually kind of interesting because the fever itself is actually a good thing. So say we stub our toe and our toe gets infected, we'll get a fever. But that fever actually makes it harder for that bacteria that got in our toe to replicate and keep infecting us. And so it's really a defense mechanism, which is a little bit more detail than is necessary, but I think it's really cool. It's really cool that our bodies just know how to respond to this stuff. And you know, it's kind of one of the pleasures of learning medicine is to understand just the logic of the body. Know, oh, I have this bacteria in my body. I should crank up the temperature so it's not able to attack me as much. So this patient, 102, a little on the high side. So we would say that she has a fever. The next one is heart rate. And this one's kind of fun. So you can actually check your own heart rate. Has anyone found their own heart rate before? Nice. Well, we can practice that now. So there are a couple ways. So sometimes you hear this referred to as pulse. And what that is the blood flowing through these blood vessels that we were talking about earlier. And so you can check that pulse by feeling a couple places on your body. So there's one that's really common. Let's see if I can get this right on the camera. Okay, so this is my wrist. Okay, this is my hand. And if you feel right here, okay, right here, then you might feel a little pulsation, a little beat, okay?
But you don't want to check with your thumb because your thumb, you could feel your own pulse. That's
exactly. So you want to feel with your middle finger and your index finger, and you feel kind of on the far side of your wrist, on the side of your thumb. Is anyone able to feel? Nice. So that's your pulse. That's blood flowing through your body that you can feel right there. Another sometimes easier place to check is up in your neck. So if I turn my neck, you can see this muscle right here. So that's something called the sternocleidomastoid muscle. So if you go into medicine, you can learn really fun words like sternocleidomastoid. Anyway, so if you feel that, you go right inside of it, right next to your windpipe, and press down with your two fingers. That's another place you can feel your pulse, okay? Who was able to get a pulse? Nice, well done everyone. You're already well on your way into healthcare professionalism, okay. So normally, if you count that, it should be somewhere between 60 to 100 beats per minute. A fun fact, if you're a really sporty person or you work out a lot, that heart rate can be much lower. It can be in the 40s. So when I swam a lot, I had friends whose heart rate was in the 40s, which under some circumstances can be seen as dangerous, but that's just to say it's a very wide range of normal. But this Miss Smith, her heart rate is 116. That's a little bit high. And that's also a sign that something is going on in the body that's not ideal, okay? The next one is a little bit easier. It's respiratory rate. So how many times are we breathing per minute? And nurses are always the best at getting this. As a trainee, I often forget because you don't want to, just tell a patient that you're going to be counting how many times they breathe. So as you're interacting with them, you look for subtle signs like their chest rising and falling, or them breathing in if it's a little bit harder for them to breathe. And so you have to be a little bit sneaky about this, but essentially you're just counting how many times a patient is breathing in a given minute. And there's also a range here, 12 to 20, but this patient's breathing 30 times a minute, which is definitely on the high side. And if you remember, Miss Smith said that she was having a bit of a cough. And so maybe there's something going on in the lungs, because when you cough, that can come from the lungs. And also when you're breathing fast, that might be because there's something going on in the lungs. So this is how you can begin to piece things together. And then blood pressure is the last one that's on the slide. I think I'm blocking one more. Yeah. And blood pressure is just what I was talking about earlier, how much strength there is in this blood flow. If it's really low, it just means that not enough blood is getting around your body. And we'll have a little video that shows you how to measure this, how we measure this. That can be kind of fun. And then the last one is how much oxygen is in the blood. It's called pulse ox. And has anyone seen those little clips on the fingers? If you've ever been to a doctor's office, they'll put it on your finger. So what that's doing is it's looking to see how much oxygen is in the blood. And it does it in a very cool, fancy physics, chemistry way by looking at the wavelengths of light. But that's kind of more detail than is necessary. But you should have almost 100% of saturation of oxygen in the blood. So this patient has 90%, that's a little bit low. So those are the vitals. We see that this patient is running hot, is breathing a lot, heart's beating fast, the pressure's a little low, and there's not a lot of oxygen in the blood. And so this is making us more concerned that there's something going on. Okay. So this is a little video about how to read the blood pressure. I'm gonna try to play this. Please let me know if the audio comes through.
We'll use 114/76 as an example.
It's coming through. Okay.
All right, so now that you know the basics, let's try a few simulations.
Okay. Did that audio come through okay? Was it kind of quiet? It was kind of quiet on my end, so. Okay. So I'll go back to just a clip in the video
We'll use
and just talk like really
114/76.
briefly about it. So these are just some numbers, these are just some numbers essentially. And what you do is you put a cuff on someone's arm. Have you anyone gotten their blood pressure read before? Oh yeah, Edie's got a cuff. Yeah, exactly. So you put the cuff around someone's arm and then you blow it up really tight, okay? And so that puts a lot of pressure, and eventually there's so much pressure that blood will no longer flow past the cuff. And so when can you guys see my pointer? Can you see my mouse?
Yes.
Okay, great. Yeah, so when the pressure is high, there'll be no blood flow. And then there'll be a time where you can actually hear the blood going through the cuff. And then eventually the pressure will be so low that you don't hear anything again. And so what this is when there's turbulent flow in the blood vessels because of this external pressure, you can actually hear it. And once there's not enough pressure and it's no longer turbulent, you can't hear it anymore. And these two numbers tell us how much pressure there is in the vessels. And this number right here, 114/76, is a good number. It's I wish we could be in person so we could do it on each other, but it's a fun thing to practice. And it's actually it's not the easiest skill to pick up, but it's a really valuable one.
We'll use 114/76 as an example.
Okay, so next is the overall physical exam. And let me just briefly go forward so I know what there is after this.
I'm also going to do the
Okay.
biceps reflex by putting.
Okay. Okay. So after that, after we just kind of see how the patient's generally doing, we want to go head to toe and see if we can pick up on anything that's going wrong. Anything in the head, anything with the heart, with the lungs, anything in the stomach. We try to go from head to toe and figure out kind of what's going on. And one of the first things, did you all get a pen light from Dr. Kwan? Awesome. So this video should show you a little bit about what we look for with the pen light.
If you look straight ahead.
All right, were you guys able to pick up on it? It's kind of subtle, but as the light is shining on the eye, you can see the pupil get a little bit smaller. And then if you look at the other side, the pupil on the other side also gets a little bit smaller. And it can get really complicated and confusing, but essentially it's just a check to ensure that certain parts of your brain are working properly. Okay, so if you have someone you can practice on now, later, that's something that you can see. You can shine a light on someone's eye when they're holding it open, and their pupil should get smaller. And it's very important for neurosurgery. It's one of the most important things that you can check, but it's very important in general. It just tells you what's going on inside the brain, because we can't always see without advanced imaging what's going on. So this provides a very quick approximation of things that might be happening. Let's see. And then I think we have some videos next. Let's see. Okay, so next is listening to the heart and to the lungs. Okay, so did you all get a stethoscope? That's something that you put in your ears and has a little bell. Okay, great. Yeah, so did you all get a chance to listen to your own heart and your own lungs? Awesome.
Yeah.
If you want to do it now, feel free. You can put them in your ears, and I can just briefly, kind of talk about what you can listen for. If you want to put the stethoscope just off of midline, so if you feel kind of the bone in the center of your chest and you go just to the left of that, to the left side of what's called your sternum, this bone, and you put the stethoscope on there while you're listening in, you should be able to hear your heartbeat. All right. Are you able to hear, Lilia?
Yeah, I heard it.
Awesome. Pretty cool, right? It's your heart. All right. So it's a good check. It's a good thing to know that your heart's beating. So if you're ever concerned that your heart stopped beating, you can just take a listen. The other things that you can listen to, if you keep them in, is if you take a really deep breath and then take a deep breath out, you can hear the air coming in and out of your lungs. And based off of exactly how that sounds, you can pick up on different kinds of disease processes that may be occurring. Okay. And this video just kind of goes over some of the sounds that you may hear when there's something going on in the lungs. Is that audio coming through okay? Okay. So that's like what you would hear normally. Okay. So you hear something like that and it's okay. And here are a couple of examples of things that might make you a little bit more concerned. You kind of hear the difference there. It sounds almost like there's something popping, like some popcorn popping in the microwave or something. Or if anyone had, I'm trying to remember the cereal, but with Snap, Crackle, and Pop. Am I aging myself right now?
Rice Krispies.
Rice Krispies. Has anyone had Rice Krispies before? All right. Yes, yes. Yeah, so it kind of crackles when you put the milk in, and that's kind of what it sounds like when there are crackles, quote unquote, in the lung. And that can be a sign of multiple things. It can be a sign of an infection or some fluid in there, or even that there's some scarring in the lungs. So it really depends on the overall clinical picture. But that's one of the sounds that we're listening for. And that's probably the most common sound, I would say, that you really hear. I don't know, what would you say, Edie? Would you say that's one of the more common lung sounds that you would hear?
Wheezing.
Yeah, wheezing. Good point. Yeah, wheezing would definitely take the cake. So if you have something like, asthma, and there's also a disease called COPD that a lot of people who, as they age, they get, you frequently wheeze with that. So I'm not sure if, let's see if there's some wheezing in here. Yeah, there we go.
All those noises are caused by different things.
Mhm.
Like wheezing can be the tightening of the airway passages. And sometimes it's hard to get the air in, and sometimes it's hard to get the air out. And the crackles can be because there's something in the lungs that shouldn't be there, some extra fluid or something like pus or something from an infection. And then that first thing, the bronchial thing, was just normal. That's just
Yeah, exactly. So you can hear it, a very distinct sound. I mean, have you guys heard someone wheezing even without a stethoscope before? Yeah, so it's fairly common. I mean, I sometimes wheeze when I work out really hard. And so it's not super uncommon to hear that, but that's what it sounds like when you have your fancy stethoscope and you're able to take a closer listen. So yeah, all right. And this is kind of a fun one. So as someone who's interested in the brain, this is kind of getting more towards things that we look for that might be going on with what we call the central nervous system, so the brain and the spine. And this is reflexes. So did you guys get a little hammer or something? Okay, all right. So we'll watch just a little bit of this video, and then I can kind of demonstrate on myself. And it's a strange feeling. So if you haven't gotten your own reflex before, hopefully we'll be able to get you guys to do it and just kind of see what it feels like.
I'm also going to do the biceps reflex by putting my hand on the biceps tendon. I'm also going to do the biceps reflex by putting my hand on the biceps tendon. And then I'm going to strike my thumb, and I will feel the contraction as well as perhaps see the muscle contract. I think one important caveat is that it's important to keep your eye glued on the muscle and not so much focused on the movement, because if it's a very depressed reflex, all you might see is a contraction of the muscle. That level is C5-6 again for the biceps. I'll now do the triceps, which you could do many ways. If he's relaxed this way, I could just choose to leave his arm in the position it is. And I'm actually getting a good reflex in this fashion. Hit the patellar tendon and notice a nice brisk contraction of the quadriceps muscle. Again, be sure to expose the muscle you're looking at. Keep your eyes glued on the muscle. Don't worry about the movement, especially the vastus medialis, which is the last thing to go when you lose the knee reflex. The ankle reflex in it, I'm also going to do the knee reflex. And again, with the patient sitting like this and very relaxed, it's quite easy to hit the patellar tendon and notice.
Okay. Oh. So that's one of the more satisfying parts of the exam, I would say. And so just to kind of demonstrate, let's see if I can kind of get my knee in frame. Okay. So if you feel your knee, you can feel your kneecap, and that's bone. And then a little bit lower, you can also feel bone. But in between the two, there's this softer region that you feel like you can kind of push on. And so if you aim between your kneecap and the bone below it and just kind of hit right there, you'll feel this uncontrollable urge to dart your leg forward. Is anyone able to get it? Yeah, nice job, Naomi, nice. So it's a really weird sensation, you know, and kind of the funny thing about that is it's actually controlled totally outside of your brain. And so what's happening is you have these little nerves that come out and they reach into this area between your bones. And then they go back to your spinal cord. And then they tell other nerves in your spinal cord to contract certain muscles. And so it all happens in the spine. Your brain can, to some degree, control it, but most of the action is going on in the spine. So it's like our spine has a mind of its own. It's pretty cool. Anyway, so Lilia, were you able to get it?
It took a couple of tries, but yes.
Nice, nice. Ranjita and Alejandra, any luck?
I was able to do it yesterday.
Nice. Well done. All right. So those are some of the fun things that we get to do with patients. Great. Thanks for the thumbs up, Alejandra. All right. So sorry for speaking for so long there, but I'll pause here again. And any questions or concerns, anything that's come up since we last paused?
Something I wanted to say is that the history is really important. And this is an example. So we have the older lady that's got the fever, got the high heart rate, is breathing fast, has got the low blood pressure. She's one thing. And so she's been in a nursing home or a home and she's not feeling good. And then those, theoretically, those same vital signs could be on one of you that just ran in a track meet. And you would be normal. Well, you were out there, it's 100 degrees outside, you're running hard, so your body's hot. You're working really hard, so you're breathing fast. And you're working hard, so your heart's pumping really fast. All those same vital signs could be on you and you be normal for what you're doing and what's going on, what your history is. And this is different with this lady. That's a little hint. She's sick and you're not. So it's just over time, you learn all these what's normal, and then you add on your information, and eventually you're able to say, okay, that person looks sick and that person isn't. It, you know, anyway, makes it kind of not a fun game, but a little bit.
Yeah, it's a great point. You know, context is everything. And so that's kind of getting back to what I was saying earlier about much of being in healthcare is being somewhat of a detective. And if there's a detective investigating a crime scene, that detective always has to put what he's seen at the crime scene in context. And it's the same thing for healthcare providers. You know, if you see a high heart rate, it could mean a lot of things. It could be, you know, like Edie was saying, you just got off of a track and you were running around, and so your heart's pumping because it should be. It's responding to the stress of you running. Or it could be your 86-year-old lady who has something going on that we need to check out because she's been in a nursing home and she just looks sick. And so, you know, we have all these facts. There's so many facts that are coming to you all the time when you're in healthcare. And it's really the job of the nurse, of the physician, to put all those facts together into a coherent picture and to try to understand what's going on. So thanks for sharing that, Edie. All right, anatomy. This is fun. This is what we all look like under the skin. And it's somewhat different than what's commonly drawn. So this is a heart. Has anyone seen a diagram of a heart before? All right, so it's not this, unfortunately. You know, it's not quite as simple as just a little heart, but it's actually way cooler. And so as long as you guys can see my little arrow, I can just very briefly walk through this. So this is the right side of your heart. This is the left side of your heart. What happens is blood comes from your body and it goes into the right side of your heart. It then gets pumped out into your lungs. It then comes back from your lungs into the left side of your heart and then gets pumped out to the rest of your body. So it's really fancy, amazing machinery that works amazingly reliably. You know, we said earlier that this is occurring this heart is beating 80 to 100 times every minute, whether you're awake, whether you're asleep, for your whole life, you know, and I don't remember the exact number, but that's got to be billions of heartbeats, and it does it reliably time after time after time. And that's how it works. So blood in to the right side from your body, and that doesn't have a lot of oxygen in it, then goes into your lungs. It picks up oxygen from the lungs from what you breathed in, and then goes to the left side of your heart and is then pumped out to the body. So that's kind of the basic circuitry. These are the lungs. Who's seen a diagram of the lungs before? A little bit more complicated looking. But essentially, so you breathe in here, goes into the mouth, comes down, goes into your windpipe, and then funnels into your lungs. And if we zoom in here to very high magnification beyond what eyes can see, this is what it looks like. This air eventually flows into these very small airways, then goes to these kind of air sacs. And in these air sacs, that's where we pick up oxygen from what we're breathing in. And the oxygen is transmitted from these airways to the bloodstream and then carried back to the heart. And these little airways here, the ones that we can't really see super well with the naked eye, are the ones that can get kind of tight in something like asthma or something like COPD and create that weird kind of wheezing sound, a musical wheezing sound that we heard earlier. So that's the lungs under magnification. This is not my personal favorite, the GI system. It's a lot of general surgeons do a lot of work with this. There's also a field of medicine. So I should mention that, you know, there are physicians and nurses who focus on the heart. You know, they work in the cardiology departments and clinics. There are physicians who care about the lungs. They're called pulmonologists, and there are a lot of nursing specialists, techs, and nurses who work on some aspect of the respiratory system. And then there's gastroenterology, another fancy name that deals with kind of the ongoings of the digestive system. And so this is what happens to food when we eat it. Okay, so just like air, it comes in through the mouth. Instead of air, it doesn't go to the trachea and to the lungs, but it goes down the esophagus, comes to the stomach, loops around to the small intestine, and then eventually into the large intestine, and then out of the body. And at every step of the way, we're pulling things out of the food. The intestines are pulling things out of the food that we need for life. And so beyond just being really fun to do and really tasty, you know, the way that we get these nutrients that we need to grow hair or to grow in height as we're maturing or to keep our skin healthy, whatever it is, you know, we're pulling these nutrients from our food through this system. So it's vitally important, even if it's not my personal favorite. Okay. Any questions about that?
Yes, I actually have a question.
Yeah.
I'm not sure if this is true, but like I heard it somewhere that I heard that the heart is able to survive outside of the body for like 3 or 4 hours. So is that true? And if so, how is that possible?
Yeah, that's a really fantastic question. So there's a whole realm of medicine called transplant medicine or transplant surgery. And what they do is when someone has some unfortunate accident on a highway, for example, and they check the little box on their driver's license saying, I'm willing to be an organ donor, people go out, take that body and might take the heart out of the body, put it on ice, and put it in kind of a bed of nutrients. And it can survive like that for a matter of, 3-4 hours, probably even a little bit more, until they put it into a new body. So I assume that's what the person was talking about, that you heard that from. And the way it kind of works is, like I said earlier, when we eat, we get all these nutrients, and those nutrients go to our different organs, like our heart, to keep it running. And so if we were to stop eating, eventually our heart would stop working because it needs those nutrients that we're eating. Well, instead of eating and getting it to our heart that way, you can just drop the heart in a big bucket that has a lot of nutrients around it. And it's not ideal, it won't last forever, but it can kind of, when soaking in that, surrounded by all these nutrients, some of those nutrients can help the heart at least stay alive until it gets a better situation in the new body. So it's a really crazy field, but it is possible.
I mean, the heart's not pumping or anything
Right.
like that. It's
Yes.
just absorbing fluid.
Yeah, it's not, yeah, it doesn't continue to pump. It's kind of like in hibernation. So it's powered down, and it's able to just get by like a bear, it's just getting by on the nutrient it stores. And then you put a new body, you can snap back up like it's coming out of winter, and start working again. Yeah, so it's a really crazy field. I actually was able to rotate on transplant surgery and saw some of this happen. People fly out, get the organs, come in, put it in someone else, and it's a really wonderful thing. And it's always very sad where the organs are coming from, but they're going to people who really need a new organ, and it can give them truly a new lease on life. There's certain diseases that if they didn't get a new organ, they would probably pass in weeks, but with a new organ, they can live for 20 years afterwards. So, it's really a very, very cool field of medicine. Yeah. Thanks for your question. Any other questions?
If I could, can I ask another question?
Of course, please. Yeah.
Okay, so on the digestive system, the diagram, like the stomach, it looks like it looks small and tiny, but I know like it's able to stretch a lot. So I guess when it does stretch, like does it affect the other organs that are like beside it?
That's also a really great question. And the answer is yes. So we absolutely can stretch out our stomach, just like we can stretch out a lot of things. And so if the stomach is used to having a lot of food or a lot of fluid in it over a long period of time, it'll adapt. Our body's very adaptable. And so it can grow. And one thing that can happen, and this isn't really pictured here, but we have something called the diaphragm, which separates our chest from our abdomen. So where our lungs and our heart are from our stomach. And there aren't a lot of holes in it. Okay. There's only a very small hole for this esophagus to go through. But when the stomach gets really big, what can happen is the stomach can push out and go into the chest. And that can cause some issues like acid reflux or heartburn, like we were talking about earlier. So it can grow, and it can cause some local issues by pushing into new areas of the body that it usually isn't in.
And you're not really talking about this, but in the same way, inside there is the uterus where a baby would be when a mother is pregnant. And when the baby gets bigger, it pushes on everything and makes your mama have heartburn, or it makes her feel like she can't breathe very well. But that's a normal thing, but it just makes you can feel sick. You can feel a little uncomfortable because of this normal process.
Yeah, so there's definitely this general concept of when something is larger than it usually is, it can kind of go around and cause expected or unexpected issues. And just to kind of follow up on what Edie was saying, the uterus where the baby lives is kind of down here. And that's also where the bladder is, what stores the urine before we go to the bathroom. And so if you've ever been around someone who's been pregnant, you may have noticed that they go to the bathroom a lot. And that's at least in part because this baby is growing and it's pressing on the bladder where all the urine is. And so it just doesn't take that much urine before it wants to flow out. Okay, so that's a little bit, maybe, I don't know, unseemly of an example, but it's the same kind of concept. Okay, so when things in the body grow, they push things around them, and that can make us somewhat uncomfortable. So yeah.
I have a question. So I'm just adding on to what Lulia said. So after it stretches, does it go back to its size, or does it remain like big?
The uterus after pregnancy?
Yes.
Yeah. So it shrinks dramatically. So I think that, I don't know the exact numbers. I wouldn't be surprised if it's just a little bit bigger, after pregnancy than it is before it, but not much. So it'll go from a certain size, and then I think it increases about the volume of it, how much fluid could be stored in it, for example, increases about 500 times. So it really grows. And then it shrinks pretty much all the way back down to what it was. So it's another example of just how amazingly flexible the body is. It's able to accommodate this crazy thing, like having another person, on board for a period of months. So yes, thankfully it does not stay huge. It does shrink back down. It might be just a little bit larger, but it does mostly shrink back down. Yeah. Yeah, of course. Great questions. Yeah, appreciate them. Anything else? If not, we can move on. All right. So this is a fun part, I think. I think this is really fun. So in addition to talking to patients, in addition to doing an exam on patients, sometimes we want to know a little bit more, and we want to see more than what our own eyes can show us. And so there are all these techniques that can give more in-depth pictures of the body than our eyes can provide. And that branch of medicine is called radiology. And so we will look at a chest x-ray, which is one of the fundamental things that radiologists will obtain to help us understand what's going on inside of a patient. So who's seen a chest x-ray before? Nice. Okay, excellent, excellent. Yeah, so I don't think I had seen a chest x-ray until my first year of medical school. So you guys are all ahead of me. But this is a chest. What organs do you think we see? And the three options are, there are two organs out of these three. Do you think that we see lungs? Do you think we see stomach? Or do you think we see heart? Which do you think we can see in this picture?
I think I see lungs.
Okay, great. Are the lungs black? Are the lungs white? Where do you think you see the lungs?
I think the lungs are the black ones because I think the white is the rib cage.
Awesome. That's amazing. Yeah, I'm super, super impressed. So the lungs are the black here that I'm outlining on each side. And then, as you said, this white here, 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 these are ribs. So if you've ever seen kind of like a toy skeleton around Halloween or something like that, this is the rib cage. And then what do you guys think this strange structure right here is?
Maybe the heart.
Awesome. Yes. Nice job. This is the heart. And yeah, really good. Really nicely done. And then just as a brief aside, this is the diaphragm that I was talking about earlier. So when the stomach gets really big, it can push up and get into the space. Okay. So yeah, so these are lungs.
So I have a question. What's in the lungs?
Yeah. Is that a question for me or a question for them?
No, for them.
Okay. Yeah.
What? Oh, you can answer that too.
No.
What do we want in the lungs?
Oxygen?
Hmm?
Oxygen?
Air. Yes. Oxygen. Okay. So when air is black, just like you said.
Mm-hmm.
It doesn't, but the things that have like substance, like bones or organs, like muscles, those are not black, they're white. They show up in the x-ray sort of opposite what you might think. But because these lungs are nice and sharp and black, it looks good. Like down here, you can see all the way down into the corner, there's it's black and nice and sharp around the heart, sharp around these bones. That's lots of air, and that's a good thing. And for an x-ray anyway.
Yeah, definitely. That's well said. So just kind of as a general rule, things that, like Edie said, don't have a lot of substance to them, things that aren't very quote unquote dense, they tend to show up darker on this kind of imaging. And so, air, we don't really even see air. I mean, there is substance to air, but it's very, it's not dense at all. And so we can see right through it. And that's why it appears as dark. Whereas something like bone, bone is pretty thick. It's pretty hardy, it's got real substance to it. And so it blocks some of the radiation that we use to make these images. And so it shows up as lighter. So tissue, bone, those kinds of things show up as white, and things that like fluid or sometimes fluid on different modalities, but air generally shows up as dark. Yeah, so, and just as kind of like a very brief overview, usually there's a certain structure to how we read these, so we make sure we don't miss anything. And that structure is called the A, B, C, D, E's. Okay, so the alphabet never goes away. You always got to know your alphabet. And the A stands for airway. And so the airway is what I'm tracing right now. That's the trachea. So you can see it's a little bit darker than the surrounding bone. This is actually, this bone back here that you can kind of see are actually, it's your spine. And so in front of that is your trachea, and that shows up as dark. And so this airway looks good. It's supposed to be in the midline, just like this, and it's in the middle, and so it looks good. The B is in bones, and so we look at all the bones and we see if it looks like there are any fractures in the bones, and these all look good. The C stands for cardiac, which is a fancy way to say heart, and so we kind of trace the heart. And one kind of quick thing that we look at is how big is the heart. If the heart takes up more than 50% of the space in here, then we would say that it's big, and it might be a sign that there's some disease going on. The D is then diaphragm, which is what I was talking about earlier. And we're looking for fluid down here. And so that would show up as not as sharp of an angle down here. And then E stands for everything else, because it didn't really fit the acronym. And that's really when we look at the lungs and we see they look nice and dark like we hope they do. So the A, B, C, D, E's, airway, bones, cardiac, diaphragm, everything else. That's a good way for radiologists to make sure that they're not missing anything when they're reading x-rays, okay? So this is a normal x-ray. There's no disease here, but this is Miss Smith's x-ray. What do you guys notice differs between these two slides, if anything?
Well, the lungs, they don't look nice and sharp as the first picture. And the heart kind of looks kind of deformed. I'm not sure.
Yeah, that's really great. Yeah, so like you said, there's doesn't look so sharp along the bottom here. And if you kind of just look right where my arrow is, on here it's nice and dark, and here it's now not nice and white. And so this is kind of a sign that something's going on in here. And you guys just have a guess, and we certainly don't, this is just for fun, not expected to know, but with something like this on imaging, kind of some fluid in the lungs associated with a fever and coughing, do you have any idea what kind of disease that may represent? Yeah, so I would have absolutely no idea. I didn't even have an idea through a lot of my first year of med school. So the answer is pneumonia. So pneumonia is an infection of the lungs, and it often shows up like this. So the lung is actually divided in different sections. And so there's a lower portion to your right lung, a middle, and an upper. And then there's the same on the left side, except there's no middle. There's an upper and a lower. So sorry, this is actually the right and the left, because radiologists are, I don't know why they did that to us, but it's always flipped in radiology. So the left side of the screen is the right lung, and the left side of the screen is the right lung. But anyway, so there are these different sections to the lung, and when one looks all white and nasty like this, that's a sign that it's infected. But that's one of the common reasons that something would show up like this. So in someone who's coughing, has a fever, and has an x-ray that looks like this, we would highly suspect infection of the lung, and we would get some cultures to try to look for bacteria and give some antibiotics to go in there and kill the bacteria that are causing the issue. So that's what's been going on with Mrs. Smith. All right, so that was the diagnosis, and that was our last official slide, okay? But we want to just stop again for any questions that you guys may have. We're happy to talk kind of more about the day-to-day of what it looks like to work in healthcare. You know, Edie's worked in a lot of different practice environments as a nurse, and so she has a lot of experience of what you'd actually be doing, who you'd be working with. You know, I've been in, you know, med school for 4 years, which isn't nearly as much time as Edie's been a nurse, but I've been able to see a lot of what it looks like to be a physician on the day-to-day. And as you know, in terms of hours, who you're working with, all that kind of stuff. So we're happy to talk about that. Happy to talk about why we think medicine is a great option. We're happy to leave it up to you guys to kind of direct things, or nothing at all. You know, totally up to you. So we'll just pause here for questions, and it's been really great to talk to you all.
Yes, I do have a question. So last
Yeah.
time you talked about how when the stomach, or I think it was the stomach, when it expands,
Mhm.
we get acid reflux, or also called the heartburn. Can
Mhm.
it be fixed, or
Yeah, definitely. So there are multiple ways to go about that. Usually when someone has heartburn and gets that burning feeling, there are certain medications that we can give, because usually it's not so much an issue that the stomach has gone up into the chest and is causing that issue, but it's just, you know, someone who might have, you know, a little bit more mass in the stomach than usual, like they're pregnant, or like maybe they just had a huge meal, or there are just various reasons why you can get reflux. And so you just give a medication for that. It's usually pretty effective. If the stomach has kind of moved up a little bit into the chest, and it's not that the whole stomach does, it's usually just a little piece, but it's enough to cause heartburn, then a surgeon can go in and pull it down and then make sure it stays out of there by putting in some nice suturing, which is a kind of thread that keeps things nice and tight. So usually it's just a medication, but if it is an issue where the stomach has moved up into the chest, an option is to go in there with surgery, pull it down, and then make sure everything's nice and tight with some sutures so that doesn't happen again.
okay, thank you.
Yeah, of course.
Yeah, and I have another question. So I know there's different types of organ transplants, like heart, kidney, all of that. So is it possible to get like a brain transplant, or is that still like too complex that we're not there yet?
Yeah, that's a great question. And it is not being done now. And it's something that people have talked about. It hasn't really made its way into common serious discourse in the worlds of brain surgeons and brain doctors and brain nurses and just brain practitioners. There's just a lot of issues. So anytime you put a new organ into someone, you have to make all the right connections. And so for something like the heart, it's actually relatively straightforward. You know, it takes blood from the body, it gives blood out to the lungs, it takes blood from the lungs, and it gives blood out to the body. And so there are really 4 major connections that you have to make when you're putting that new organ in. With the brain, the number of connections that you have to make are huge, because every nerve in your body, everything that controls my hands, my feet, my mouth, you know, all those nerves are coming from the brain. And so you have to make all those connections. And it's really hard. There's never been any demonstrated ability to restart the function of the brain when it's out of a body for any length of time. So the brain is kind of the prima donna of the body. It's really sensitive about everything. And so you couldn't take the brain and put it in this medium to get its nutrients like you can the heart. You take the brain out, if it doesn't have oxygen, if it's not getting its blood, then it won't come back online. And so it's just very, very sensitive. There's always, I mean, I'm so tempted to go into kind of the latest emerging research and all this stuff. There's a lot of really exciting stuff that goes on all the time. And so there's some really cool research articles that have come out within the last year that speak to this directly. But suffice it to say, if that ever happens, which honestly, I would be surprised if it happens within my lifetime. But if it does, I'd say it's like at least 30 years down the line before that's kind of a serious thing. It's not impossible theoretically, but there's so many obstacles right now to keeping the brain happy and making all the connections that it's not done. So yeah. But it's a great question. And I mean, as someone who's interested in the brain, you know, I could talk forever on that. So thank you for that.
Another question.
Yeah.
Do nurses have the time to go and have fun? Because I know that they work a lot of hours. So because I just don't want to be in, I just want to I don't want to be working all the time. I want to go and have fun, you know.
Yes. There are lots of different ways you can work as a nurse. You can work 12-hour shifts where you work maybe 3 days in a row, 12 hours a day. That's your whole week, and then you get 4 days off. Sometimes they schedule in different ways. And when you're young like you are, you're able to do that. I have worked, after I had my daughter, I would just work maybe 1 day a week. You know, if you're married to somebody and maybe they're making money also, then you can just work a few hours. And so that's a beautiful thing. You could just work, you know, a day or 2 days or something. Some jobs you can work 6 hours a day and have the rest of the day off. You know, it depends on you. I have known people also that work like double. They need the money to support their family, so they have 2 jobs. And I personally could never do that. But you know, if times are tough and you need the extra money, then some places you can make what we call time and a half. You get extra pay for working these extra hours. And so that's, you know, it's kind of a positive thing if it's needed. But there really are lots of, you can work different shifts. You can work nights where you go in at 7 p.m. and come out at 7 a.m. You could work like 7 to 3 in the, you know, 7 in the morning till 3 in the afternoon and still have time off, yes. But depending on where you work as a nurse, hospitals are always open. People are always sick. So you will have to work Christmas. You will have to work New Year's, you know, depending on where you work. Right now I work at the health department. We're closed. We work Monday through Friday. We're closed holidays. That's one reason I like it. So there are gives and takes, you know, it's important. Doctors are important. People that are sick are important and they need to be cared for. So when you go into any of these fields, you have to be willing to sacrifice some of your time, some of your favorite stuff maybe, but for the betterment of other people. And it's a choice you have to make. Does that make sense?
Yes, it does.
Okay.
Okay, I'll ask another question. I don't know if I should ask this question or not, but I heard that Albert Einstein, when he passed away, his brain was kept. Is that true?
Sorry,
Albert Einstein.
Oh, when that his brain was kept?
Yeah.
Yeah, so this is actually a really fascinating story. Okay, so I don't know if any of you have heard of a radio show called Radiolab. Anyone heard of it? No, it's okay. It's kind of a niche thing, but it's kind of a popular science podcast, and so they just talk about interesting stories in science. Anyway, they actually have a whole bit on this, and so what is thought to have happened with Einstein's brain is when he passed, there was a lot of interest in it because this guy was a genius, of course. And so people thought that there must be some structural explanation for why he was so smart. And so there was almost a bidding war over his brain. Everyone wanted his brain. Everyone wanted to study his brain. I'm going to do this with his brain. You know, people were submitting proposals for what they were going to do with the brain, how to make the most out of it, so on and so forth. But it's all a little bit under the table because someone's body, even after death, is their property. And so they can decide what they want to do with it. And it wasn't entirely clear what Einstein's relatives wanted to have done with it. And so what seems to have happened is his body for a while was just kind of floating around the hospital system that he passed in, and then someone in kind of the deep south got his hands on it and stored the brain and for many years just in his own personal house. And many years later, a news story came out about it and kind of traced the brain of Einstein back to this individual who had just been keeping it. And so people came to his house and like, do you have Einstein's brain? You know, and he's like, well, actually, yeah, I do. And so people came and he gave the brain over to them, and they did a lot of research on it. And kind of his whole motivation was, I want the brain because I think it's important, but I don't believe we have the tools right now to really study it. And so I'm going to take it off of the market, so to speak, and hold on to it until we're smart enough as humans to really study it. And so he held on it to like 20 years or something like that before people came knocking. And yeah, so that was his brain. Then people studied it, and kind of the main thing that they saw that was different in his brain was that his parietal lobes were really large. And so you can kind of think of the brain as having 4 main lobes, and it's of course much more complicated, but we have our occipital lobe, which is kind of in the back of our head, and that covers our vision. So the way that we can see is because we're getting all this light in through our eyes, and our occipital lobe in our brain interprets that. We have our temporal lobe, which are kind of within the ears, just going straight in. And that's where a lot of our memories are, okay? And we have the frontal lobe, and that's a very complicated lobe that we still don't understand super well, but it controls behavior, controls a lot of really complicated decision-making. And so it's a very, very fine-tuned and complicated portion of the brain. And then we have the parietal lobes, and those control our ability to move around in space and do math. And so his parietal lobes were really big. They were about 15% larger than your average parietal lobe, which may not sound like a lot, but the normal deviance from the mean is not nearly 15%. So he had huge parietal lobes. And, you know, some people think that at least part of his genius can be attributed to the fact that his brain was seemingly wired to do that. And there are a lot of other theories that came out of that, but yeah, sorry to go on a ramble, but the answer to your question is yes. People did keep Einstein's brain for many years in a house. It was then confiscated, research was done upon it, and now we know a little bit about Einstein's brain. So a very, very strange story.
Thank you.
Yeah.
And I also have a question for Gray. You said you're still in medical school, and then after this, you're gonna go to residency, and then maybe do fellowship. So I guess, how do you stay motivated? Because that is like a lot of schooling that you have to do, and you still have a few more to go. So what kind of keeps you motivated? And like, are you able to have fun and do other things than, you know, just do schoolwork?
Yeah, definitely. You know, I think those are really important questions for any career you could be considering, you know, in healthcare or not. You know, how much am I going to have to devote to my work? How much reserve am I going to have for some enjoyment outside of work? But to kind of answer your first question about how I stay motivated, you know, I think that a lot of people in healthcare view it as somewhat of a calling. You know, they view it as something that they're driven to do, they're passionate about. And, you know, the level varies, of course, but I'm just very passionate about what I'm able to do. I find all the science really fascinating, and I find the people really amazing. And so getting to be in the hospital and meet people, learn who they are, learn what brought them to this point, talk to their family, follow them over, you know, days to weeks to months, see how they do with the surgery, see how they're feeling afterwards. It's just a really special privilege that we get as practitioners to be able to enter into people's lives at a very vulnerable spot and to walk with them through it. And so I think having that personal connection really keeps me charged and keeps me motivated to try to find better solutions for these people, because there's still so much that we don't know. There's still so much that we're unable to do. And so meeting these people, you know, really enjoying these people, having a love for these people, and seeing that they need better care, it really motivates me to keep studying, keep working. And, you know, I'll be honest, it's definitely, there are a lot of hours, you know, to kind of go to your second question, you know, what am I able to do kind of outside of work? I would say medical school itself, you know, it's busy, but it's pretty manageable. I would say that I would average, you know, maybe 60 hours of work a week for school that I need to do. And so, you know, a full-time job, quote unquote, is about 40. And so we do about that. Then we have to study a lot of evenings. And so it's maybe a little bit more than kind of a typical 9 to 5 would be. And then residency is usually a really intense portion of training. And so just to kind of give you an idea of what my daily schedule will be like when I start, I'll be waking up at around 4:30 and getting into the hospital around then, and then working at the hospital till probably around 7 p.m. most days. And then every 4 to 5 nights, I'll be staying in the hospital overnight and taking care of any issues that come up. And I'll be working at least one day of every weekend. And so that's during that intense training portion where you probably do work, about 80 hours a week for, 5 years or so. And it's a lot, I'll be honest. But after that, you do have some flexibility. So, even though that training is kind of locked in, that's how much you're going to work, whether you're going into brain surgery or whether you're going into pediatrics. After that, you can decide, do I want to set myself up to continue to work those hours, or do I want to throttle back and make sure that I'm home by 6 every day? And in almost every field, you can do either. You have to be intentional about it. They're not going to give you your time, without you fighting for it. But there are definitely people in every field that have great balances between their work life and their home life. And so I would say it definitely can be done. But there is a very intense period of training that lasts about 5 to 10 years where you're going to be working more than, maybe you'd like to for a time. But if you're really passionate about it, it's absolutely, I think, worth it. And hopefully I'll still say the same thing when I'm on the other side of all the training. So, yeah.
I have to say, when I was like your age, I thought that I wanted to be a doctor.
Mm-hmm.
But when I went to college and I saw the people that were really strongly pre-med, they call it pre-medical, they were studying all the time. And then I thought, if you get to be a doctor, they call you in the middle of the night and they ask you questions about people, and you have to be smart. 2 o'clock in the morning, you get a phone call and, oh, Miss Jones is really sick. I thought, maybe I don't want to be a doctor. And so that's why I went into nursing. So I think you all are curious and you're asking questions and you're looking at things. I think it's great. And you will figure out, all right, what are the options for me? Do I want to be a doctor? Then you're going to go for it. Or it's like, okay, maybe not that. Maybe what else is there? There's lots of options. And so just keep looking until you find the fit that's good for you.
Yeah, I would definitely echo that. And just say, even beyond kind of the hours you're working, there are a lot of important differences in terms of, kind of what your work life looks like when you're, say, a physician versus a PT versus a nurse. Like, for example, nurses get to spend a lot of time at the patient's bedside. And we as physicians would really rely upon them to let us know what's going on at bedside, because we're often in the OR or making calls or charting, doing stuff online to make sure all the documentation looks okay. So the nurses are at the bedside a lot, and so they really can get to know the patients very well. I think a lot of times even better than the physicians can, and that can be a really attractive thing because people are awesome, So that's a really cool thing. Whereas some physicians do a lot of research, and so that you can do that as a nurse. It's just not necessarily as common. And so if you really want to probe new scientific questions, being a physician and coupling that together works pretty well. And so they're just differences. There's no right or wrong answer. Hours differ, kind of what you get to do differs. But as you kind of explore these things and try them on for size, you just have to feel what's right for you, whether that's in healthcare as a field or not. But I know definitely there are a lot of great options. I'm very passionate about medicine, and so it's definitely, I think, if you're interested in it, definitely worth the work, but it certainly is work. So. All right. Any other questions, concerns? If not, it's okay.
Eddie, can we please get your email as well?
Okay. Zoom people. Do I just did it.
You got it? If not, I can type it in.
Okay, cool.
Oh, sorry. Stop
It's not in the
sharing.
chat. I just did it to Ranjita.
Okay. If you want to say it, I can type it.
It's, oh, let's see, edie@flippinfamily.org. It's my name. Let me see. I can do it.
Oh, okay.
Everyone can.
Yeah, you got it on the chat.
Great. Even you will have my email and we can be buddies.
Sounds good. Yeah.
I have to say, my mother had cancer 9 times. When she was very unusual, she had this genetic thing. And so her last cancer was in her brain. And she had many, many surgeries, and like a lot of them in her belly and different places. And it would be really painful and terrible. And it would take a long time for her to get to feeling better and moving around and all that after all these other surgeries. But we were thinking, my sister and I were there when my mother was going to have her brain surgery. And we thought, this is going to be horrible. All that belly stuff, that was terrible. This has got to be worse. It's the brain, right?
Yeah.
But the neurosurgeon said, no, tomorrow she's going to be feeling okay. She might have a little headache.
Right.
It's crazy. My mother woke up from that surgery and just had a little headache. She got to get up out of the bed. She walked. It was not what I expected.
Yeah, that's great. No, I think
It's funny. That's a very important thing. Just,
right.
It doesn't hurt.
Exactly.
Like
Yeah.
that. It's just weird.
It is weird. We don't have nerve endings in the brain itself. Our brain shoots out all these feelers everywhere else in the body, but it doesn't really feel itself. And so you cut into it, it doesn't know. So a lot of times patients feel okay after brain surgery, and there often is kind of a sense of surprise, but it's nice as a provider, to have people pleasantly surprised, be like, oh, I thought this was gonna be terrible. It's bad, but it's a lot better than I was expecting. So that's definitely more enjoyable. Yeah. Well, everyone, it was super nice to talk to you all. Thank you so much for taking the time. Please reach out, as questions come up about anything. But I think it definitely speaks a lot to your seriousness and intelligence that you're spending some of your Saturday afternoon here asking great questions and listening in. So we really appreciate it.
It was fun.
Thank you, guys. Thank you.
You're very welcome.
All right. Y'all take
Thank
care.
you.
Of course.
Yeah.
Thank you.
Of course.
I guess that's what I could do, is I could just close the breakout rooms.
Oh, okay. There's no rush, I guess. But one group I think just joined us. Gray's group. Gray's and Edie's group.
Yes, we just finished.
We were having a lot of fun.
Yes.
Let's see here.